Okay. Good morning. I'm Mylan Torres. Thank you for coming and joining us for the Winship Grand Rounds. If you're joining us online and are an Emory University or Emory Healthcare employee and you want to receive CME credit for attending today, the login information can be found in the chat feature at the bottom of your screen. If you have any issues with the webinar or the CMA login, please send Kariatu Fafana an email or drop a note via chat to that feature. This morning, we are pleased to welcome Dr. Gita Suneja. Dr. Suneja is an associate professor of radiation oncology at the University of Utah School of Medicine, an investigator at the Huntsman Cancer Institute, and an adjunct associate professor in the Department of Population Health Sciences at the University of Utah. Her clinical specialties include the radiation treatment of breast and gynecological malignancies. Dr. Suneja earned a bachelor's degree in applied math from Northwestern University. She graduated from Brown University from medical school and completed her residency training in radiation oncology at the University of Pennsylvania. She is an accomplished physician scientist with a commitment to cultivating a cancer health equity, as well as promoting diversity and inclusion in the medical workforce. She holds several notable national leadership positions, including serving as co-chair of the National Comprehensive Cancer Network Guidelines, NCCN panel on cancer in people with HIV. She's also the vice chair of the Radiation Oncology Institute Board of Trustees, which really sets the research agenda for radiation oncology nationally. She's also the current vice chair of ASTRA's Health Equity, Diversity, and Inclusion Steering Committee. She has received many awards to support her research, including those from NIH, NCI, countless foundations, and the Huntsman Cancer Institute. She has over 90 publications in high-impact peer-reviewed journals, such as the Journal of Clinical Oncology and Lancet Oncology. With her unique skills and passions for combining clinical radiation oncology, health equity research, and training the next generation oncologists, Dr. Suneja is enhancing the quality of cancer care for all people. Welcome, Dr. Suneja.
Hi, good morning, everyone. Thank you so much for that beautiful introduction. I think the Zoom camera is right there. I'll say hello to people who are on Zoom. And we will get started. So I think Dr. Torres, let's see, really beautifully went over my disclosures. These are my funding disclosures and my committee service disclosures. And we'll just jump right in. So over 40 years ago, a little over 40 years ago, the CDC published a report of 5 young, healthy men who developed a lethal form of pneumonia. And this was in their weekly MMWR report. Just a month later, they published a series of 41 young men who developed an extraordinarily rare form of cancer, Kaposi sarcoma. And the New York Times picked up that story, and with that, the world was introduced to human immunodeficiency virus. It wasn't until 15 years later that the tide began to turn for HIV. And I think that now that we've lived through and are living through the COVID pandemic, you can really feel how significant a time period that was. If we hadn't had vaccines and therapies that were available for this period of time, it would have been really even more devastating than it already was. Of course, we know this is like the holy grail graph in science that we're always going for in oncology. Introduction of protease inhibitors coincided with rapid decline in deaths from HIV. Survival of people living with HIV has improved. And actually now the life expectancy of somebody with HIV is the same as somebody who doesn't have HIV. So it's really become a chronic disease, which is important for the work I'm going to show you today. So what do we know about the landscape of HIV malignancies? We know that the US HIV population is aging and growing. We know that cancer is a leading cause of mortality in this population. In fact, it's the leading cause of non-AIDS death in this population. And we also know that people living with HIV have worse survival from cancer than those who are uninfected. And so how and why did cancer treatment disparities become a focus of investigation? So this is a really simple conceptual model. I actually put this together for my very first job talk many years ago. And I have come back to it again and again. There's much more beautiful and complex models out there, but I've come back to this as sort of like a North Star of where to go with this research program. And I would encourage those of you who are starting out to really think about what you're doing now and where it's going to lead you down the road, and have something like this, a conceptual model or a framework that you can go back to again and again. So of course, health services research is the science of healthcare delivery, and treatment disparities is kind of within that larger umbrella. And the first step is really just to recognize or suspect that there may be a disparity at play. And that often comes from clinical observation. So this is me, probably about, I guess, almost 15 years ago now. I was a resident at the University of Pennsylvania, and I saw a patient who had HIV and lung cancer. And the attending and I were a little bit unsure of what exactly we should be doing. We weren't sure if the radiotherapy was going to be tolerated as well. We didn't know if there were interactions between the systemic therapies and the antivirals. And I went to the literature and found really a lot of kind of conflicting information. Here's the literature. Here's me conflicted. So there were older case reports of really severe radiotherapy toxicity in this population, but almost nothing on non-AIDS defining cancers. Most of the literature was really around management of lymphomas, of cervical cancer, of Kaposi sarcoma, very little on managing lung cancer, breast cancer. And so that kind of got me thinking, if we're at an institution with the world's literature at our fingertips, what was happening in other places where information was less readily accessible? Were these patients even being treated appropriately? So in my research, I came across these 3 articles that had been recently published within the last year or so. And all 3 of these used a data set called the HIV/AIDS Cancer Match Study. This is run out of the National Cancer Institute. And at the time, the PI of the study was Dr. Eric Engels, who's shown here. Now, Dr. Engels and Dr. Shields are co-PIs of this study. So I cold emailed Dr. Engels and said, hey, I'm a resident. I'm interested in using your data set. I'm wondering if you'd want to collaborate. Again, for the learners in the audience, you never know when someone's going to respond. And this, in this case, has resulted in a decade-long collaboration and friendship. So if you see something that you read out there and you're engaged and interested in it, I love hearing from people who want to collaborate at different institutions. And of course, it's become a lot easier now that things are so accessible by Zoom. So the HIV/AIDS Cancer Match Study, what it does is it links individual state cancer and HIV registries. And it's currently available in 14 states. It's one of the largest studies of cancer in people living with HIV. And what Dr. Engels is an infectious disease specialist, what they were doing was using this data set to look at cancer risk in people with HIV. So they were looking at the whole HIV population and trying to figure out what was different about those who were developing cancer. I was interested in the opposite. I wanted to look at the cancer population and figure out what was going on in terms of cancer treatment for those who had HIV. So I went to the NCI. Let me see if I can move this. Okay, so I went to the NCI and we did our first study looking at adults with lung cancer in Texas between 1995 and 2009. Why did we choose Texas? This linkage was not collecting cancer treatment data from the cancer registry because that wasn't the focus of the study. So Texas was up for renewal. This linkage was up for renewal. So we had the opportunity to ask for cancer treatment data, which is readily available in the cancer registry. So we looked at receipt of cancer treatment as our primary outcome. Because we were suspected a disparity, we used a very broad definition. So any chemotherapy, any radiation, any surgery, we counted as having received treatment. Because what we didn't want was to show a difference and then have people say, well, you used a really narrow definition of cancer treatment. So we were very broad, really any kind of treatment we counted. And then in this study, we secondarily looked at survival. We had 337 patients, which doesn't sound like a lot, but at the time was one of the bigger studies of people with HIV and lung cancer. And what we found was that people with HIV were less likely to receive cancer treatment compared to uninfected controls. And these are all adjusted analyses. And you can see the odds ratio is pretty significant. It's pretty harrowing, the magnitude of the difference. Both HIV and lack of cancer treatment were associated with higher mortality. So I'm married a Texan. I like to say Texas is a special place for many different reasons. That study kind of got us started, but we wondered, would we see the same difference in other places and other cancers? So the scope of the study was narrow and we wanted to broaden the scope. So we looked at doing a second study. This time we had cancer treatment data from Connecticut and Michigan as well. And this time we looked at 10 common cancer types. So we looked at 2 of the AIDS defining cancers and then several, you can see listed here, of the non-AIDS defining cancers. We looked at care patterns only this time, so we didn't look at survival. And we modeled in this study, so in the prior I showed you the odds ratio. In this study, we modeled lack of cancer treatment. So you'll see the odds ratios are all flipped. And this was the largest study at the time of cancer treatment in people with HIV. And what we found is that HIV was associated with lack of cancer treatment for most cancers. And I've circled the ones where this was a significant finding. We didn't meet the threshold for significance for cervix and breast. That's because we had a very small number of cases of those cancers. That is expected because in the US HIV population is largely male. It's about 80% male. So we expected to see fewer cases of these cancer types. And we also didn't see a difference for anal cancer. And I want you to remember that because we're going to come back to that in a little bit. We did a second analysis here where we looked at 5 cancer types and defined what we called the standard treatment modality, which is the treatment modality without which you could not be going for a cure, right? So one of these treatments would have to be administered to be giving curative intent treatment. And we found even greater disparities for some of the early stage cancers. So again, early stage cancers, highly curable, less likely to get treatment in these cases. So a couple strengths of this study, there were a large number of patients. The cohort was consistent with the US HIV population demographics. So we felt like we were kind of on the right track in terms of figuring out what was going on here. But there were also some really important limitations. There was no information on insurance status. And we know that in the United States, people living with HIV are more often or more likely to be uninsured or underinsured. And we also know that people with no insurance or some forms of governmental insurance are less likely to receive cancer treatment. So as was pointed out to us by several reviewers, what if this phenomenon we're seeing is entirely driven by insurance status and not by HIV, and it was something we couldn't control for. We also didn't have information on medical comorbidities. So we know that comorbid conditions are more common in people with HIV. And of course, as we all know, that also affects candidacy for cancer treatment. So to answer these questions, we needed to go to a different data set. And so we went to the National Cancer Database. I love being here because all of these organizations are like right down the street. So we went to this, we worked through the intramural program at American Cancer Society because they don't release HIV at that time. They weren't releasing the variable for HIV status. And so as many of you probably know, having worked with this data set, it is a hospital-based registry, so it's different from state cancer registries, which are population-based, and it represents a very large proportion of incident cancers diagnosed in the US. For this study, because we were trying to isolate the impact of insurance, we looked at adults who were under 65 years of age, who were diagnosed in a more contemporary period, so 2003 to 2011. We looked at several of the most common cancer types in the HIV population, and HIV status was determined through reported comorbidities, which is why we went internally through the program so that we could access that information. This, again, at that time, the largest study of cancer treatment in people living with HIV. And what we found is, as predicted, a greater proportion of people with HIV had Medicaid, Medicare, or no insurance. And higher comorbidity scores. So that's what's shown highlighted here. The general cancer population was about 73% private insurance. Those with HIV were about 35, 36%. And then if you look down at the second circle, there is where you'll see comorbidities. So this is what we expected. And then we wanted to factor this into our analysis. And we found that even after factoring in differences in insurance and medical comorbidities, HIV was still associated with lack of cancer treatment And this time, I don't have any circles on here because it's significant for every cancer type except anal cancer. So we had a lot more cases of cervix and breast cancer, so we were able to more effectively look at those. And so again, I want you to remember anal cancer as an example because we're going to come back to it. So what about other data sets? What's being shown in these other arenas? So SEER Medicare is a data set that links cancer registry information with payer information from Medicare. And so there are these two studies looking at HIV and lung cancer in the SEER Medicare database. And what they found was HIV was associated with higher mortality, but the cancer treatment did not differ by HIV status. So how do we explain these differing outcomes? Well, as you all know, Medicare patients have uniform coverage of medical care. And also, this is an older population. So the vast majority of people who are eligible for Medicare are older. So they're 65 years or older. There are some medical conditions which allow you to apply for Medicare at an earlier stage, but the vast majority of the population are over 65. And so we know that older cancer patients in the general population are less likely to get cancer treatment because of performance status, comorbidities, patient refusal, and sometimes appropriate de-escalation of care. So we're often looking for strategies like active surveillance, omission of radiotherapy for patients who are older and may not reap as much of the benefit of doing these therapies at a younger age. And indeed, we did this paper. This was led by Ann Rossich, who's a faculty member at Johns Hopkins, looking at SEER Medicare, looking at 10 common cancer types, and found that the cancer treatment disparity was really there more for the younger Medicare population, so the 66 to 70 age group. When you looked at those 70 and older, we really didn't see that difference as much. This is a newer paper by Dr. Jessica Islam, who's a mentee and collaborator at Moffitt. She used the National Cancer Database to look at palliative care use. And I think these findings are really fascinating. So palliative care was defined as any surgery, radiation, systemic therapy, or pain management that was administered with non-curative intent. This was a very large study, so included a lot of people living with HIV and cancer. And what she found, I just find this so striking, is that people with HIV with stage 1 to 3 cancer were more likely to receive palliative care, less likely to receive curative therapy. And people with stage 4 cancer were less likely to receive palliative care. So it's this really, when we first saw this finding, looking just at palliative care, we thought, oh, great, early palliative care, that's perfect. That's what we know that improves outcomes for all patients. But then we saw that was coming at the expense of doing curative therapy. And then the population for which we would really strongly recommend palliative care, stage 4 patients, were less likely to receive it. Other endpoints of interest, so we know, those of you who are clinicians know, cancer treatment is not a binary variable, right? In all of these registry and database studies, we've looked at it as binary, but we know the quality of care really varies. So the type of chemo, the number of cycles, the radiation dose. And so this is a smaller study. It was retrospective, multi-institutional, looking at people living with HIV and oropharyngeal cancer. And what they found was that there were significant delays in initiation of therapy for those who had HIV. The radiation dose used was significantly lower, and people living with HIV had worse disease-free and overall survival. I don't know if anybody uses index cards anymore, but index cards were a staple of my childhood studying. Sometimes the more you learn, the more confused you are, right? You set out to sort of investigate a problem, and then you get all this data, and it's hard to kind of make sense of what it means and where to go next. And that's where it's important to have something to go back to and say, okay, what do we do next? So we suspected this disparity. We documented it using secondary data from a bunch of different sources. And so really the next step was try to understand, why are we seeing this difference? What is driving this difference in cancer treatment rates? And for that, we really needed to turn more to primary data collection. So we had some hypotheses about what might be going on. We knew there were likely health systems factors that were at play, so timely referrals, the complexity of the healthcare system, interdisciplinary collaboration between oncologists and HIV specialists, We knew there are likely patient factors, so dual management of disease, the stigma of HIV and cancer, and of course, financial toxicity, which we know is a big issue for all people who have cancer. And then we also hypothesized that there were physician factors, so lack of prospective data, lack of consensus guidelines, and possibly provider bias, given how much had changed in the HIV treatment landscape. So we thought we'd start with the physician factors. So just a note on the prospective data. So for many, many years, people with HIV were excluded from cancer clinical trials. These were blanket exclusions. So any diagnosis of HIV meant you could not go on a trial. In the last several years, there's been guidance from CTAP and guidance from the FDA suggesting that's not appropriate. And what we should be doing is only excluding people with HIV if there's a biologic rationale. So if there's a hypothesized mechanism where HIV or the antiretrovirals might interfere with the drug or the therapy that's being treated. But what we see in practice is that there are still these blanket exclusions, or the inclusion criteria are so overly restrictive that even people with well-controlled HIV are not eligible. So what does that mean? That means the best available evidence we have, we don't know if it applies to people with HIV. The treatments are equally efficacious and equally well tolerated. And there were no consensus guidelines at this time to sort of help with that area that where we are in a data-free zone. So let's go back to anal cancer. So I showed you that in all of our studies, that was the one cancer type where we didn't see a difference. And these are the NCCN guidelines for anal carcinoma around like 2013. There wasn't a lot of information, but there were these two lines addressing how to manage people with HIV, just kind of signaling that patients should get the same treatment. We might need to do some adjustments, but they really ought to get the same treatment. So this sort of led us down the path of thinking this might be more of a knowledge gap. And so we designed a survey study. We surveyed 500 medical and radiation oncologists that were randomly sampled from the AMA master file. And our primary outcome was self-reported delivery of standard cancer treatment to people who had well-controlled HIV infection. So we gave little kind of like case vignettes. And we asked the medical oncologist, how likely would you be to offer standard chemo, lower doses or fewer cycles, or discontinue treatment? And then we asked the radiation oncologist about lower doses, smaller fields, or discontinuing treatment with early side effects. And all of these were rated on a Likert scale. And what we found, so we had a 60% response rate. Dr. Jaxie helped me design this study and figuring out how to elicit. Oncologists are notoriously difficult to survey, and so 60% doesn't sound that great, but we were proud of that number. And what we found was that about 20 to 25% of the surveyed oncologists, or the respondents, would not provide standard therapy. And if you remember back to some of the tables I showed you earlier, that's about the magnitude of difference in cancer treatment rates. We did some factor analysis looking at several other questions we'd asked and how they related to this primary outcome measure. We found that differences in cancer treatment were driven by concerns about toxicity and efficacy, as well as comfort discussing side effects and prognosis. So oncologists that felt like they could sit down and talk about how HIV was going to impact the care and the outcomes were much more likely to offer cancer treatment. A couple of findings that weren't our primary findings, but were really compelling. We found that 45% of respondents said they rarely or never discuss their management plan with an HIV specialist, which kind of makes sense, right? Where we have fractured healthcare systems, it's maybe hard to reach out, particularly if you're in a community practice setting. You don't have a shared electronic medical record. You may not have contact information for that person's HIV specialist. 70% indicated that sufficient guidelines were not available for treatment decision-making. Okay, so now we're starting to move the needle on trying to figure out why we're seeing this difference. And the big gap, as a health equity researcher, I think we do a great job of documenting disparities. We are starting to do a better job of explaining drivers of disparities, but the big gap we have in health equity research is actually providing solutions. And so I would encourage all of you, if, academia really rewards kind of publishing into the void, right? We publish, we get our work into high impact journals, other academicians read it, but that doesn't move the needle for patients, right? That doesn't get to the patient. And so really thinking about what will you do with your work How will you translate it into action and advocacy that's really going to change an outcome for the population that you're interested in? It's always good to have that in the back of your mind so that you avoid this trap, I'll call it, of the hamster wheel, just publishing and doing more work and never actually affecting change in medicine. So I would encourage all of you. I've done lots of publishing into the void, so it is part of what we do, but thinking about like, what's the next step? How are you going to actually take this and do something with it? So in this case, we felt like guidelines was a really good place to start because we recognized from this survey that there were knowledge gaps. The respondents told us there were not sufficient guidelines in an overwhelming majority. So the National Comprehensive Cancer Network, probably all of you are familiar with, is an alliance of 33 leading cancer centers. They have multidisciplinary panels that meet regularly and develop guidelines on cancer management. And I think a big key is these guidelines are available free of charge. So they can be downloaded anywhere and you don't need to pay for the guidelines. So in 2016, I went to the NCCN and made a pitch to the steering committee for a new guideline. And basically what we did was we showed our data and explained that cancer is a large and growing problem in this population and that the management is complex and the literature is of varying quality. So I mentioned before about these older case reports, really not a lot of modern guidance, particularly from the non-AIDS defining cancers. And what we learned from our survey was that although there are a few kind of high prevalence, high incidence areas, for the most part, a lot of the cases were dispersed. And so it wasn't like people with HIV-associated malignancies were all going to New York or San Francisco. There were many, many cases and many providers who were seeing patients for the first time who didn't have experience treating this population. So we recommended that the NCCN convene a panel of experts to generate guidelines. We anticipated immediate impact on patient care. And really, it was meant to be a starting point because the body of literature in this area is rapidly evolving. So the AIDS Malignancy Consortium is an NCI-funded clinical trials cooperative group that designs and executes trials specifically for people with HIV. There's also the NCI, Center for Cancer Research, that does trials in this space, and then many investigator-initiated studies and retrospective, very large retrospective data sets like the VA and Kaiser. I just wanted to point out that you have a very robust HIV malignancy research program here at your institution. This is Dr. Lisa Flowers, who's the PI for the AIDS Malignancy Consortium, and Dr. Jolyn Tulin, who's in the audience, who was an AMC she received an AMC scholarship to serve as a fellow and do research in this space. So tons of exciting work going on right here in this space as well. So the steering committee agreed that this was a need, and it took a couple of years, but in 2018, this guideline was published, Cancer in People Living with HIV. And I co-chair this guideline with Dr. Erin Reed, who's my colleague at UCSD. And I'm really proud of the fact that we have very broad representation from multiple disciplines. So we have radiation oncology, medical oncology, surgical oncology, pathology, and we also have our colleagues from HIV medicine, pharmacy. We have patient advocates on this panel. And so it's really an amazing group. This is the 2018 group. This has since evolved. And the current group is, of course, available on the NCCN website. So what we did with this guideline panel is we covered 4 cancer types, 1 AIDS-defining cancer, 3 non-AIDS-defining cancers, but really created some sections that were unique for this population. So principles of HIV management. Not that we expect oncologists to do the HIV management, but we wanted them to be aware of possible changes that might need to occur to encourage this collaboration between oncologists and HIV specialists. We have some really amazing detailed drug-drug interaction tables. Dr. Michelle Rudick was the pharmacist who worked on those tables in this first iteration. And then principles of like supportive care. So for example, things like steroid use. Not always appropriate or indicated for people with HIV. It really depends on the clinical situation. Similarly, principles of imaging. So there's more greater likelihood of benign lymphadenopathy. So how do you handle that? Those are the kinds of things we address. And this guideline with our Kaposi sarcoma guideline was downloaded 50,000 times in the first year, which suggested to us that there was a need for this information. So the key points of the guideline are that HIV status alone should not be used for cancer treatment decision-making, that co-management with an oncologist and an HIV specialist is necessary. And then in future iterations, we're hoping to add more cancer sites and also incorporate more HIV-specific data. So another area that's rapidly growing is kind of looking at HIV stage, HIV parameters, and how that influences cancer treatment. Again, some of that work being done here. One idea that we had that did come to fruition in 2021 is so the guidelines are not necessarily intended for use worldwide, but they are used worldwide. And so there's a lot of recognition on the part of NCCN that the cancer treatment approaches, and this is for all guidelines, not just this one, that are detailed are not appropriate for all settings, this particularly low resource settings. And so they have a program called NCCN Harmonized Guidelines that goes to areas where these cancers are common and create kind of modifications of the guidelines with providers in country. And I really like this approach because, to be honest with you, people in this particular guideline is in sub-Saharan Africa have much more experience treating people with HIV and cancer than we do here, right? In Botswana, for example, the HIV prevalence is much, much higher. It's about 25%. And so a lot of the investigators that are part of this harmonized guideline have far more experience. So we learned a lot in this process working with them. And this guideline is also available on the website. Okay, so we're starting to get some things in our solutions column. So what to do next? I think we realized that a lot of the work we had done was population level data. And to really start to move the needle, we needed to look more at individual patient and provider perspective. And so the Career Development Award that I applied for really was meant to look at these do more qualitative research and learn more about what was going on in the care continuum with providers and patients. And Dr. Angie Fagerlund, who's the chair of Population Health Sciences at the University of Utah, is my primary mentor on this award. So we first looked at patient perspective. So we hadn't done any work to this point with patients other than our patient advocate on the NCCN panel. And so we did this study at Duke, where I was on the faculty before I was at Utah. This is Kelsey Corrigan, who was a medical student at Duke at that time. She did her research here in my lab, and she's now a radiation oncology resident at the MD Anderson Cancer Center. And then this is Brandon Knettel, who was a postdoc at Duke in the Duke Global Health Institute, is now faculty in the School of Nursing at Duke. So we did interviews with 27 people living with HIV. And we had 3 different populations from which we were sampling. So those who had already completed their treatment in the past, those who were actively under treatment, and then a group that we called treatment challenges, or a group who had discontinued treatment or were considering discontinuing treatment because of challenges related to treatment. We did qualitative analysis using constant and comparative methods. And what we found were that, as many cancer patients would describe, side effects was a big barrier, so that wasn't a surprise. But some things that were unique to this population were stigma. So 67% of patients reported stigma as a barrier. Accessibility issues, financial burdens, mental health difficulties were also very common in this population. And you can see some of the quotes. There was this prevailing theme of people getting diagnosed with HIV, learning to live with it, and then being sort of re-traumatized by the cancer diagnosis and coming into the cancer healthcare system, reliving that, sort of receiving a potentially fatal diagnosis. So one of the couple of compelling quotes: after I was diagnosed with cancer, I thought I almost died of AIDS and now I'm going to die of cancer. And I was in a bit of turmoil. And then a quote kind of representing this challenge of dual management. I missed a lot of doses of drugs because I just didn't have the energy to do anything. This is a lot to take in. You're not meant to take in this whole figure, but the light blue color is the treatment challenges group. And you can see this isn't a study that's powered to look at differences between these groups, but you can see that the light blue group had more negative experiences with provider communication. HIV was never discussed during their cancer care. And then you can see down below in the facilitators that the darker blue group and the gray group were much more likely to have these support mechanisms or facilitators like friends and family, resiliency from the HIV diagnosis. So for some patients, the diagnosis of HIV actually created a lot of resilience that helped and translated into the cancer care realm. Okay, so as part of this, we also wanted to look at the physician perspective. So we know physician recommendations strongly influence the cancer treatment patients receive, yet we didn't know how these recommendations were being communicated. We knew that sometimes it wasn't being discussed at all, and we knew that patients were less likely to get treatment. So we were kind of curious, how are people even talking about this and broaching this subject? So we did a qualitative study to characterize physician decision-making. We interviewed 25 oncologists from 2 academic centers and 5 community practices. And these were our interview guide sections. So we asked about cancer treatment recommendations, how the HIV diagnosis influenced those, what kind of baseline HIV information providers were using to make decisions. We wanted to explore what kinds of decision support tools would be helpful, because the ultimate goal of this work was to create something that people could use at the point of care. And then we talked about treatment recommendations and patient preferences, how that factors in, and then care coordination and demographics. And this study was just published a couple weeks ago in the Red Journal. And the work, the first author is Valencia Henry, who's a medical student who came to Utah to work with me for the summer through the Astro Medical Student Fellowship Award, which funds students from underrepresented backgrounds. She did a phenomenal job on this. And we have a second paper coming out that's led by Ashley Corey, who's a medical student at the University of Utah. So what we found was that ways in which we could, so kind of barriers to providing cancer treatment decision-making and ways to improve it are listed here. So almost all providers said they had no formal training on HIV malignancy. So it wasn't included in the curriculum at any point in their training. Multidisciplinary collaboration was a big opportunity to improve. Enhancement of social support services. Honestly, that's, I think, true for the general cancer population as well, but probably likely to benefit this population disproportionately. Dissemination of guidelines and point of care tools was an important, and then addressing bias in the healthcare system. This one was really interesting because what we found was a lot of the physicians we interviewed said, I would like to discuss HIV, but if somebody else is in the room and I don't know if the patient has disclosed their status to that person, they didn't want to bring it up because they didn't want to inadvertently disclose status, which is a good thing, but it kind of translates into lack of discussion. So we have been thinking about like how to approach that and how to possibly remedy that. So other areas of science that we have branched out into. So we have the lab has some translational studies going on, which is a new area of science for me, to evaluate the impact of HIV on cancer genomics and the tumor microenvironment. So we're using institutional biorepositories. We're using Total Cancer Care, which is a national network of biospecimens that are correlated with clinical cancer data. And similarly, the Orion network is very similar. This is funded through a supplement from the NCI. And then we have this R01 called the HIV Gap or Genomic Aging Project, looking at accelerated aging in the population of patients who have HIV and cancer. And the PI of the study is Dr. Anna Coghill from Moffitt Cancer Center, who's been a long-term collaborator in this work. We also have regional collaboration. So the Mountain West, Utah is not known as an HIV hotspot. We were just talking about this last night. But when you look at the entire Mountain West region, there's a lot of HIV and there are very, very few resources. There's no Center for AIDS Research. There's no AIDS, there is now, but there wasn't an AIDS Malignancy Consortium Center. So very few resources for these patients. And actually Las Vegas is an area where there's very high HIV prevalence. So we started a collaboration with UNLV looking at cancer treatment rates. That study is ongoing, but just anecdotally, what we found is that people with HIV and cancer in the Nevada Cancer Registry were even more likely to not receive treatment than the national trends that we see. And then another area funded through a NCI supplement is global oncology work, looking at cancer stigma in Malawi. These are my colleagues at the University of Utah, Dr. Steve Kamani and Dr. Melissa Watt, who we are working with to examine this idea of cancer stigma, both in people with HIV and those who don't have HIV. And then exciting news, Huntsman Cancer Institute has joined the AIDS Malignancy Consortium. So we're super excited to be able to offer novel trials to this population for patients who are living throughout the Mountain West area. Okay, so back to this again. You guys are probably getting tired of seeing my conceptual model, but we're now working more towards these solutions. So we've got clinical guidelines, we're working on decision aids, clinical trials for people living with HIV. I just want to take a look back. I said at the beginning that I created this conceptual model for the first job talk I was giving. And at that time, we had, if you can see my pointer, this study, the study of lung cancer in Texas, had been published. The second study had been done, but it hadn't been published. And everything else with these dotted lines down here was really, these were just ideas. Like this was just, we could go in this direction. These are things we could possibly do in the future. And over the last 10 years, we've really accomplished most of the things on this list. But I just want to let the early career stage and learners know this is not a linear path. Like when you see a talk like this, sometimes it's like it's just laid out and it seems so linear and it seems like everything fell into place. But there are a lot of setbacks and there are a lot of failures and there are a lot of projects we tried to do that didn't work out. There were lots of funding rejections and manuscript rejections. And I think the message I wanted to share is that if you find an area of science you're passionate about, you have to stick with it and you just keep working at it. You find mentors and sponsors, collaborators, and mentees who will help you elevate the quality of your science. And eventually you'll get there. It might take a while, but it's been really fulfilling to work in this area. So conclusions, cancer is a leading cause of mortality in people living with HIV. And in the US, people with HIV and cancer are less likely to receive cancer treatment. We know that there's patient, provider, and health system factors that drive these disparities, but really the focus of my lab has shifted in the last couple of years to looking even more upstream at some social and political determinants of health that predispose people with HIV to developing cancer and cancer treatment disparities in the first place. We know that we need multidisciplinary, evidence-based, and community-based intervention. So we collaborate closely with our community partners in Utah who are doing advocacy for people living with HIV to make sure that the things we're coming up with aren't like ideas that happen in the ivory tower that have no relevance to the community themselves. And there's just an enormous number of people to thank for this work. That this work I'm sharing today reflects the really the passion and the perseverance of a lot of different people. I have collaborators from all these different institutions, and we've been lucky to receive a lot of funding to do this work. I wanted to highlight a couple people. So Dr. Reshma Jagsi, who's also in the audience, she came to the University of Pennsylvania as a visiting professor when I was a resident, and for the last, I guess, it's been almost 15 years now, has been a steadfast sponsor and mentor and really an inspiration. So I wanted to thank her. Maya Stevens she is the manager of our lab. She joined us a little over a year ago and really helped us grow in scope and in size. And she is a Georgia native and will be coming back here in the fall for medical school. And of course, now that I'm here, I can see why she was so eager to get back because it's so beautiful. And then this is a picture of our lab I think from 2021. And we've probably doubled in size, but having the opportunity to work with the staff and the learners in our lab has been such an enriching experience. And like I said, they really elevate the quality of the science. They ask important questions and are going out into the world with health equity at the forefront. And so I'm really proud of them and feel grateful to work with them. And I will be happy to take any questions. I can also stop sharing my slides so I can see questions on the Zoom. Stop and share.
I've always found excluding people with HIV from clinical trials to be like kind of interesting because there are a lot of other comorbidities that we have never excluded people for.
Yeah.
For example, we had enough equipoise to run a randomized trial of metformin in stage 3 lung cancer.
Mhm.
But I guess my question is, where do you think that the exclusion of this population really originated from?
Yeah, that's a great question. So I'll just repeat it so that the people on the Zoom can hear. So the question is, we don't typically exclude people with other medical comorbidities. So where did these exclusions come from? I think initially they were probably meant to be protective. So there are a lot of, there's some special rules for people with HIV, for example, in the funding arena. So NCI will expedite review of proposals that are related to HIV. And this dates back to that era where we were really trying hard to generate evidence for therapeutics for HIV. So for example, if you submit something to a study section, it will get reviewed earlier than everything else that's submitted in that section, or it'll get reviewed actually with the prior submission thing. There's a different deadline. So I think they may have originated as a sort of a protective mechanism, but now I think it is two things. One is there's a lot of copy paste in our era, right? You get a trial from somebody who you know who did a trial, and a lot of the inclusion and exclusion are just carried over, particularly if it's the same disease site. So I think that's one element of it. And I think the other element of it is there's still a lot of misconception about HIV prognosis. So we've submitted manuscripts to high impact journals where you would expect the reviewers to have, knowledge of baseline HIV management or at least outcomes, and get comments back like, well, these patients all die in ER. So we're not sure that this is a relevant finding. Of course, that's not true, right? But I think people who may not be as familiar with how HIV has become a chronic disease, like cardiovascular disease or diabetes, there's this perception. And that's, I think, what perpetuates the stigma also and perpetuates this continued exclusion from trials.
Has the HIV and cancer linkage registry that you worked on with Dr. Engels and Dr. Shields expanded reports? That seems quite small.
That's a great question. So it has expanded and contracted. So it's changed a lot over the years. I think when we did those first studies, there were maybe 11 or 12 registries, and then it expanded at one point up to 17. The quality of the data really varies from registry to registry. And then during COVID, there was it was very challenging to continue some of these registry linkages. So it has changed over time. The composition of states has changed over time. So they've included some states that are very high yield for this population. And some of the states that have fewer cases are not. Let's really check here and see if there's.
There's a separate tab for Q&A.
Oh,
I
there
think you're
is?
in the chat. I think that.
Oh, there we go. Perfect, okay. So at your cancer center, are you routinely working with infectious disease team for every HIV patient treatment? That is a great question. So we have really strong collaborators in our HIV clinics who partner with us on the science. We don't have a routine patient navigation or intervention service where we collaborate with them, but I think that's what we're moving towards, because we just were able to invite somebody from the HIV clinic tab, the community advisory board, to join the community advisory board at Huntsman Cancer Institute. So we're really trying to encourage more crosstalk and more collaboration. But I think some of the things, particularly patient navigation and honestly maybe physician or clinical team navigation and support, might be helpful and a possible intervention that could start to move the needle. The next question, the exclusions came from the early studies that bridged before PI that showed worsening outcomes and increased deaths with full dose therapy. Yes, that's very true, particularly in lymphoma. So the guidelines and suggestions were half dose treatment. So this goes back to the idea of these case reports and published literature showing really severe toxicity in people living with HIV in an earlier era. Yeah. Thank you.
Developing specifically
Yeah.
HIV.
Yeah.
Could you talk a bit more about this?
Yes, so AIDS Malignancy Consortium has a portfolio of trials, some of which are open internationally and domestically, and some of which are more focused or more feasible domestically. And they cover the range of things. So there are some specimen repository studies, but there are also interventional treatment trials. So for example, immunotherapy is a big area where people with living with HIV have largely not been able to access that treatment, which, as we know, is now becoming the standard of care for many different cancer types. And so there is some data from other groups showing that immunotherapy is safe and well tolerated, but these are meant to be larger scale prospective trials. So one issue is generalizability of the trial, right? If we don't include the population, we don't know, as I said, if the results are applicable. But another issue is really of justice. Like people with HIV should be able to get the most cutting edge treatment. And the most cutting edge treatment right now is immunotherapy. And so these trials make those treatments accessible. So they actually, a huge study that was just published from AMC that many of you might have heard about is the Anchor study, which looked at doing anal cytology for for HSIL and anal precursors or predispositions for people living with HIV, and it showed a benefit. And that study was huge, multi-institutional. This study was run here at Emory as well, and it was recently published. So it really runs the whole gamut from prevention to treatment to survivorship. And I would encourage you to go to the website and check it out, because you are an AMC site, and a lot of those trials are available to you and your patients.
Great talk, and congratulations on your journey and your efforts to really collaborate with other people.
Thank you.
One comment and one question. So with the NCBB and the palliative care findings,
Yeah.
I think particularly for those who are not familiar with the NCBB, you know, those abstractors derive that information from the medical record.
Yeah.
So there's no box where it says this is palliative care,
Mhm.
this is definitive care. As we know, goals of care are very important.
Yeah.
So I think just from a strictly observational database, that people just need to take this findings as some caution. My question is really in your conceptual model, which I really like. When you go to explaining the reasons for the disparities, you sort of go directly to oncology, and then you start to explore with oncologists. But I think there might be a step in between there, because in our work, where we, of course, these people living with HIV are at high risk,
Yeah.
so they do not necessarily yet have a cancer diagnosis, they're at high risk, and they need to be screened. There are no clear guidelines about who should be screened and when. I think that's an area that would be really appreciated.
Absolutely.
Their care is primarily done by ID specialists.
Mhm.
And it's the patients themselves tell us they don't get counseling about prevention, and yet there's high rates of smoking and alcohol use. They don't get screened, they're not really referred for screening at a good rate.
Yeah.
So have you looked at that in that sort of intervening step before you get to
Yeah.
oncology?
Those are great points. So for sure, you have to know the limitations of the data set you're using, right? There's no perfect data set. Every data set has information that's missing from it. Even our qualitative work, it's a small sample, right? So it is not, you have to be careful about how you extrapolate results. So that's a great point. And thank you for bringing that up. As far as prevention, yes, absolutely. So the interesting thing is that our first paper, we had a hard time getting published in an oncology journal. We felt strongly that oncologists should be the audience, but there was just lack of awareness, because it makes up a very small proportion of any one of our practices, unless you specialize in HIV malignancies. The ID specialists and the HIV docs, they've known about this problem forever, right? They've been treating people with HIV cancer for a really long time. And so that first paper was published in AIDS because it was a much more receptive audience. So there are people looking at screening and screening guidelines. So Keith Siegel is an investigator. He's a pulmonologist actually at Mount Sinai. He has a study looking at the parameters around screening, because lung cancer is so much more common in people living with HIV. So should we be screening earlier? Should HIV be a criteria, or should the criteria be modified? So there's some really amazing and fascinating work that's going on in that space. But you're right, we do need to look more upstream. And that's where, you know, this idea of kind of looking at stigma, other social determinants of health, and how they influence screening, prevention, and other intermediaries to even the development of cancer is really important. And we know there's disparities all along that spectrum and care continuum. Yeah.
So your work is clearly inherently about an intersection between people who can't do people who can't be.
Yeah.
And I appreciate how difficult it can be to then layer on any other intersections, but I really appreciated your comments about how, well, Texans may be different and, oh, guidelines might be different. Okay. I'm just wondering, you know, given your expertise in public health equity more generally, has there been work from your group or others that has looked at the intersection of this intersectional population with other identity characteristics, particularly things like race and ethnicity, sexual gender minority status?
Yes, that is a great question. So people living with HIV in the US are parts of many other marginalized groups that are often excluded from cancer treatment. So in the US, the HIV population is predominantly Black males. And we know that race and ethnicity are big determinants of or drivers of disparate cancer treatment, largely fueled by racism. Race is a social construct. So yes, there are. So Jessica Islam, who did the palliative care study, is also looking at doing, she's working on like a multi-level determinants model, looking at different social determinants of health. I showed a couple of them, like insurance status, but there are many other things that influence it. And actually a common critique we get from reviewers is, how do you know this is HIV? Right? If this population is also part of these other marginalized groups, how do you know that it's not being driven by something else? And that's a challenge in our qualitative work, because as you saw, a lot of the barriers overlap. And it's hard to parse out. I think with our population data, we've taken the available variables we've had and controlled for them. But as you know, and those of you who do health services research and use these data sets, there are so many unmeasured variables. There's so much out there that confounds the picture that isn't captured in a variable in these data sets. There's a lot of work to do next, but I think that's where we need to go next. Yeah.
You again for really spearheading a lot of this work. Notice that patients general population.
Yeah.
And if they're also getting community access. Anecdotally, I've seen patients now, you know, there's
Yeah.
still so
Yeah.
starting to work.
Yes, I haven't been good about repeating the question. So that question was about age of cancer diagnosis and developing second malignancies. And the answer is yes. So in all of our population data and registry data, we see that people with HIV are diagnosed earlier. It varies by cancer type, but for things like lung cancer, it's quite a bit earlier. So the median age is about 45 at diagnosis. So yes, it can and probably should influence our screening guidelines. So an example of that, again, not as many women with HIV in our population data sets and registry data sets, but maybe we need to do earlier screening for breast cancer, or maybe we need to do differential screening for cervical cancer. And so those are being explored. But yes, recognition that cancer occurs at an earlier age. In all of our studies, we looked at first cancer diagnosis. We excluded patients who were coming in for their second diagnosis because we were looking at cancer treatment. We wanted to eliminate the barrier or the variable of, you know, whether somebody didn't get treatment because it was their second course. So we don't have as much information on people who are coming in with second, third, and fourth cancers, but I agree with you, anecdotally, we do see that quite a bit as well. In our qualitative data, we did see patients who had more than one cancer. Yeah. Yeah. Uh-huh. Yeah, yes, that's a great point. And there, I think I would say there's a parallel research program for HIV malignancies in different low resource settings. It's very context specific, as you might imagine. So for example, in Botswana, I worked on a prospective cohort study when I was at the University of Pennsylvania, and we actually found that cancer treatment rates were higher for people with HIV because they were already engaged in care. So they were already coming to get treatment for HIV, so they were plugged into the healthcare system. Whereas those with a cancer diagnosis who didn't have a prior medical condition were more likely to see like an alternative healthcare provider before they came into the medical system. So I think it's very context specific, but for sure there are efforts and initiatives. I think one big driver of disparate care in low resource settings is just the general availability of cancer therapeutics, right? So radiotherapy isn't as readily available. A lot of the cancer chemotherapies are not as readily available, or there'll be gaps in their availability, which we now see here too. But you know, you start out with a regimen and that drug isn't available, and so you have to switch kind of mid-course. So I think in the low resource setting, bringing more resources to elevate the overall level and quality of cancer care is probably one main strategy, but there is a big focus on people with HIV as well. They also have different cancer types that are more common. So Kaposi sarcoma is a lot more commonly seen because of the high HIV prevalence. Great. Thank you so much for the great questions.
Thank you, Dr. Suneja, for an outstanding presentation, and congratulations on all of your accomplishments and great work, clearly having an impact not only nationally, but internationally. I just wanted to remind everyone that next week, we will be having Dr. Alexander Thomas from Wake Health presenting on breast cancer care, the road ahead at Winship Grand Rounds. And to view all upcoming Winship Grand Round lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. So thank you, Dr. Suneja, and thank you for spending the day with us. We really appreciate you taking the time to visit. All right, bye.